Hey everyone, and welcome to the MediByte channel. I'm absolutely thrilled to have you learning with us today. As a healthcare professional, I completely get that talking about labor and delivery complications, well, it can sometimes feel a bit overwhelming, right? But understanding exactly what's happening inside the body, that is incredibly empowering. So in today's explainer, we're going to take a close look at two critical, though thankfully uncommon complications, placenta accreta and umbilical cord prolapse. My goal here is to break down the clinical science into clear, easy-to-grasp concepts so you can understand exactly how medical teams identify and treat these conditions to keep both mom and baby completely safe.
Okay, let's dive into this. Here is a quick look at our agenda for today. First, understanding placenta accreta. Second, identifying risk factors. Third, diagnosis during pregnancy. Fourth, treatment and safe delivery. And finally, umbilical cord prolapse.
All right, Section 1. Understanding placenta accreta. Let's get right to it.
So when we talk about childbirth, obviously, a lot of the focus is on the baby, right? But the placenta plays an absolutely vital role. It is literally the life support system. But what happens when its connection to the mother's body doesn't behave quite the way it should? Well, placenta accreta is a medical condition where the placenta develops an abnormally firm attachment to the uterine wall. Normally, that attachment is just temporary. It's designed to do its job during pregnancy and then naturally leave the body. But in the case of accreta, it anchors itself far too deeply and stubbornly right into the uterus.
To really grasp the danger here, comparing a normal delivery to placenta accreta really helps clarify things. In a standard delivery, after the baby is born, the placenta just naturally detaches. The mother can then push it out by herself or maybe with a little gentle help from her doctor. However, with accreta, because it's anchored so firmly, parts of it actually remain stuck inside the uterus after the baby is delivered. This delays the delivery of the placenta, and honestly, that delay is where the real danger lies. It significantly drives up the risk of severe, life-threatening bleeding and infection. It's exactly why healthcare teams take this so seriously.
Which brings us to Section 2. Identifying risk factors. Now, what's really interesting about this slide is how certain medical histories actually combine to elevate a mother's risk. And understanding who might be at a higher risk helps us, as healthcare providers, monitor expectant mothers much more effectively. Just as a quick side note, rates of placenta accreta are actually on the rise here in the US, mostly tied to increasing cesarean deliveries, so having a prior C-section is a known risk factor. Having placenta previa, which is where the placenta covers the cervix, is another. But if a mother has both of these present in her current pregnancy, her risk goes up dramatically. Other things to look out for include being 35 or older, having multiple prior pregnancies, or having uterine fibroids. Even prior uterine surgeries or lining disorders like Asherman syndrome, which is essentially scarring, can place a mother in a higher risk category.
Moving right along to Section 3, diagnosis during pregnancy.
Now, I know hearing about these risks might sound a little scary, but I want to reassure you. Modern obstetric medicine is incredibly proactive. If a mother has the risk factors we just talked about, doctors don't just wait around. Between 20 and 24 weeks, they'll start doing periodic ultrasounds. If those images are a bit fuzzy or unclear, they might order an MRI to get a really good look. But what if there were no prior risk factors and it just wasn't caught ahead of time? Well, during active delivery, a doctor will immediately suspect accreta if the placenta hasn't delivered within 30 minutes after the baby's born, if it can't be separated by hand, or if trying to remove it causes profuse bleeding.
All right, Section 4, treatment and safe delivery.
So the crucial point is how we manage this proactively to prevent danger. When placenta accreta is caught before labor begins, the medical team creates a highly specialized controlled birth plan. The gold standard treatment here is a scheduled procedure called a cesarean hysterectomy. This is usually planned for about 34 weeks, well before natural labor kicks in. So Step 1, the team prepares for the surgery. Step 2, the baby is safely delivered via C-section. And Step 3, and this is key, rather than trying to peel away that stubborn placenta and risking massive hemorrhage, the surgeon actually removes the entire uterus with the placenta still firmly attached inside. This is absolutely the safest way to prevent life-threatening blood loss.
Now, you might be wondering, can the uterus be preserved, especially if a mother wishes to have more children in the future? Sometimes, yes, doctors can try to preserve it using various techniques, but this heavily depends on exactly where the placenta is and if the bleeding is manageable. If the bleeding is extremely heavy, it's just not an option. And even with a standard hysterectomy, it's a lengthy surgery requiring prolonged bed rest, which introduces serious risks like blood clots that can travel to the lungs, known as a pulmonary embolism. Because of the sheer complexity of these risks, this procedure absolutely has to be done by a highly experienced surgical team at a hospital fully equipped for severe complications.
And that brings us to Section 5, umbilical cord prolapse.
For this final section, we're going to shift our focus away from the placenta and talk about another uncommon but highly critical complication involving the umbilical cord. So, what exactly is a prolapse? Basically, prolapse of the umbilical cord happens when the cord drops down through the vagina ahead of the baby during delivery. And why is this an immediate emergency? Because as the baby comes down, their body can press heavily right on that prolapse cord. That physical compression can actually cut off the fetus's blood supply. So as you can imagine, this requires immediate medical intervention.
And this brilliantly illustrates the two very distinct ways this condition can present itself clinically: overt versus occult prolapse. Overt prolapse is the obvious one. The amniotic membranes have ruptured and the doctor can physically see the umbilical cord protruding. Occult, on the other hand, literally means hidden. The membranes are still intact, you can't see the cord, but it's trapped and compressed inside the uterus, usually by the baby's head or shoulder.
Let's break down the specific clinical triggers and exactly what we do about them. With overt prolapse, you'll often see this in a breech presentation, when the baby is coming feet or buttocks first. Or it can happen if the membranes rupture early and a sudden rush of fluid literally washes the cord out ahead of the baby. The treatment here? An immediate C-section delivery. In fact, until that surgery begins, a doctor or nurse will literally hold the baby's body up and off that cord just to keep the blood flowing. No kidding, it's that urgent. Now for an occult, or hidden prolapse. Doctors usually spot it by seeing abnormal heart rate patterns on the fetal monitor. The fix here can sometimes be as simple as changing the mother's physical position to relieve the pressure, but occasionally a C-section becomes necessary here as well.
So, considering everything we've looked at today, how do these interventions keep mothers and babies safe during complex deliveries? Well, the answer really lies in the highly structured, proactive nature of modern medicine. By spotting risk factors early, utilizing advanced imaging, and having rapid surgical protocols ready to go, what were once catastrophic complications can now be managed methodically to protect both our patients.
Thank you so much for taking the time to learn with us today. I really hope this structured look at placenta accreta and cord prolapse has been informative and maybe helped demystify things a bit for you. If you appreciate this clear, visual approach to healthcare education, please hit that like button, share this explainer with anyone who might find it helpful, and make sure to subscribe to the MediByte channel for more trusted medical explainers. We absolutely love empowering you with knowledge. As medical science and imaging continue to rapidly evolve, it leaves us wondering, what new interventions will we develop next to make even the most dangerous childbirth complications a thing of the past? Stay curious, and I'll catch you in the next one.